So by way of disclosure, I am the president, CEO, and founder of 3D Biopsy. So prostate biopsy, we've gotten ourselves into a real pickle, and the pickle is not the PSA. Everybody reads about the PSA, and I think Dr. Liepman said this very well. It's really the tool we use after the PSA to find out whether or not that patient has prostate cancer. And we're still doing lots of prostate biopsies, 1.2 million times a year in the U.S. and 3.4 or more million times worldwide. We have 180,000 new cases of prostate cancer, and 95% of all biopsies are done by transrectal approach. It hasn't changed. And it's an office procedure, and only 5% are done by transperineal approach. Truss biopsy is an office procedure, and it really takes very little time. Even if you're doing it with MRI, it's not a long procedure, whereas bringing a patient to the OR and doing mapping biopsies, urologists don't want to leave their office. They don't want to be spending an hour or so in the OR doing these procedures. So there's not an incentive, even though it may be a better procedure in terms of finding more cancers, there's not a lot of incentive, at least with current technology, to be taking patients to the OR to do a mapping biopsy. It's kind of interesting in terms of the modern development of ultrasound-guided biopsies. Two articles came out simultaneously in 1987. One was Fred Lee's article about using the spring-loaded gun and an ultrasound to do a truss biopsy. And at the same exact issue was an article by Guy Valenciennes doing the same procedure, but rather using a transperineal approach. Of course, we know who won that debate. So 30 years ago, 30-year-old technology, and we're still doing the same. Now, the imaging is definitely much better than it used to be, but the biopsy tools are no different than they were 30 years ago. So when I retired from clinical practice in 2012, I decided that it's time to innovate new ideas because we really needed them, number one. And number two, I had, in the 10 or 15 years before retiring from clinical practice, I had struggled with doing truss biopsies on my patients who had seed implants, and now they looked like they were getting some of them local failures because the PSA was going up. So it'd be 0.2, 0.3, 0.6, and you sort of knew that that patient was at risk for local failure, and I wasn't finding any of those cancers with truss. So I said, well, it makes sense to bring them to the OR and do mapping biopsies, and sure enough, we found the cancers, and then we took those patients for targeted focal therapy. So that was my introduction to doing transperineal mapping. It was because I wanted to find those local failures after brachy. So this is the instruments that we all use. Either it's a side fire, an end fire. There's some evidence that the side fire probe is a little bit better in finding the ultrasounds. The probes have gotten better. They're no longer mechanical sector. When I started brachytherapy in 1990, we had a mechanical sector probe, the 8551B and key, and we had what I call the buckboard to hold the probe. It was pretty crude, but that's how we started. So it hasn't really been much change. They've gone from mechanical sector to linear array, but they're still doing the same thing. So another issue that's we all know about is tumor multifocality. And one of my concerns with trying to identify the index lesion, and that's the primary driver of decision making, is we're forgetting about all the other tumors in the prostate. And in fact, this is Dave Boswick article from the Mayo, the average number of patients that have multifocal tumors approaches 70%. So if you found a larger tumor and it's the index lesion and it's a Gleason 7 to 10 and you're deciding that I've got it, that patient needs definitive therapy, you're golden. But if the tumors are smaller and we're now starting to think about treating patients with focal ablation, if we're just targeting the index lesion, that may not be adequate. And here's an example, Gleason 6, typical scenario. You think this guy has a type of cancer that is good for active surveillance, but you've missed the Gleason 7s that are there in the anterior of the prostate. That's really the main concern I have, is that we're going to be led down a path to believe the patient has a disease he doesn't really have, especially if those lesions are small, which they are today. When we started doing trust biopsies in the late 1980s, you couldn't miss that cancer if you closed your eyes. But what's happened over all the years of PSA screening, we went from 100,000 new cases of prostate cancer in 1989. We introduced PSA early detection. By 1993-94, we had 350,000 new cases of prostate cancer, and then the numbers started to drop. And the reason why they dropped is the incidence of cancer has not changed. It's still the same. The prevalence of disease has been wiped out by the fact we had early detection. So now we're moving to a realm of better imaging. We've got MRI. MRI is much better than ultrasound in finding smaller lesions and finding anterior lesions. There's no question about that. But what's going to happen is if we all switch to MRI and we find all the lesions that MRI can find, and those are the 1 centimeter, 7 millimeter lesions, we're going to be left with MRI invisible lesions, unless the technology gets much better, which it could, and those lesions will not be detectable, but the patients will still have the same number of Gleason 8 to 10s, which are the ones we want to find early. So that's my fear. Maybe it won't happen, maybe it will, but it's happened already, and the odds are it'll happen again. When we introduced imaging for renal stones, ultrasound imaging, when somebody presented with flank pain, we found many more renal cell carcinomas, and now they've gotten smaller and smaller. There's no change. That's going to be the same thing that happens with prostate cancer. So a couple studies, and you could criticize the studies for definitions. This is one study I like from France, where they had 10,000 prostatectomies and 919 patients who fit strict criteria for active surveillance. They were T1Cs, PSA under 10, and just one positive core out of 12 was less than 3 millimeters of cancer, and a Gleason score less than 7. And what they found was that 26% of the patients who you would have thought were good candidates for active surveillance, only 26% had insignificant tumors. Yes, maybe they were too stringent on their definition. Maybe that number should be 50%, but still, a large number of patients would not have been candidates for surveillance had they chose that option and had they not had prostatectomies. I'm not going to belabor the issue about trust biopsies because we all know that infection rate's gone up, and as Dr. Liebman said, we need to have a better strategy, maybe rectal swabs, to reduce this increasing risk incidence. The patients are out there dying. We're not seeing a lot of reports by here, anecdotal stories of patients dying of sepsis from trust biopsies. Now, it's interesting. I'm going to show some data on our mapping biopsy procedures and complications. I didn't get this paper accepted to the AUA, but last year we had the trust mapping paper accepted, and we didn't find any increased incidence of infections with repeat trust biopsies, and that's the same thing Dr. Liebman said. But this year, when I decided to analyze the incidence of infection and the number of biopsies done per session, so going from 12 biopsies to 18 cores. So think in terms now of MRI, you're taking 12 systematic biopsies and you're taking another 4 or 6 targeted biopsies. You're up to 16 or 18 biopsies. We found a relationship. If I dichotomize the data between 12 and less and 12 and more, there was a much higher incidence of infection in the men who got more biopsies per session. So that's just our data, not published yet. Just keep that in mind, that there may be a greater risk of infection with the more pokes you put in the prostate transrectally, and that may be more, that should drive you more maybe to want to do rectal swabs to make sure that patient does not have a fluoroquinolone-resistant infection. Bottom line, when we do trust biopsies, only 20 to 25% are positive. At least 25% need to be repeated because they're false negative. We need to take precautions to prevent serious infections. It has extremely limited usefulness, I believe, for selecting active surveillance candidates. This is without MRI. Can't be used for selecting patients for targeted focal therapy. You get no localization information. And it's really hard to change practice patterns of our colleagues because they're so used to doing a trust biopsy in the office. It takes them 10 minutes, next patient, and the government doesn't help us because we continually get hammered on reimbursement, so we get paid less and less to do more and more, so we want to do it more quickly. So the whole system is a total mess. And I'm not sure I have a solution to all this, but maybe. So this is one of the articles I like. Now, Dr. Raston had talked about the group at UCLA. Maybe their technology or technique wasn't as good as they had at the NIH or what he has at Saudi, and that's true. But I think it's going to be a given that imaging can only detect lesions down to a certain size. So if you're dealing with multifocality, so this is a MRI, then radical prostatectomy, and they're looking at what MRI detected and what MRI missed. So on the solitary tumors, it's much better. It missed very few. But if you're dealing with multifocality, the miss rate is substantially higher. And they're not missing the big tumors. They're finding tumors greater than a centimeter in size. These are linear, not cubic centimeters. But if you look at the smaller tumors, smaller multifocal tumors, 89% were missed. So if you remember the lecture yesterday about the Gleason 9 to 10s, you don't want to be following these patients, and then when they become large enough, you're finding them because it's probably too late for a Gleason 9 or 10. Admittedly, that's a small number of patients. We don't have a lot of Gleason 9 to 10s. But if you're even looking at the Gleason 7s and 8s, it missed 29% of the Gleason 7s and 38% of the Gleason 8. A lot of my colleagues will say, well, if we put those patients on active surveillance, those things will grow large enough, we'll finally find them with an MRI, or their PSA will go up a year later, we'll rebiopsy them, and that's fine. But do I want a Gleason 8? That's half a cubic centimeter growing in me? Because that's already 500 million cells. Probably the answer is no. So can we do a better job in trying to find some of these more aggressive cancers earlier? The answer is yes. And can we do a better job, especially in patients with multifocality, of Gleason 7s and higher, finding where they are in the gland and then coming up with a strategy to ablate them that doesn't require a whole gland therapy? And the answer is yes. So is transperineal mapping biopsy the solution to this dilemma? So this is Dr. Skouteris. He's a fellow of mine working in Athens, Greece, and this is your typical scenario. You have the biopsy gun going through the template. He's looking at the ultrasound. You can see the prostate there. You can see the needle going in. He's taking a biopsy there. It looks just like the MRI that Dr. Raston had showed you, but there's no MRI overlay. So this is what I was doing. He was my fellow at Mount Sinai when he learned this, and he does this now routinely in his practice, and that's part of the data set I'll show you. But you're not going to get more than 5% of urologists to do this. This just takes too long, and there's no way to record the lesion. And when you take a biopsy like here, and you want to take a full biopsy, you got to put the needle in again, and you got to start from here and go to the back, because you got to do inline biopsies. Otherwise, you're not taking a core from the whole length of the prostate. And if you think that you're getting the needle in the exact same place, you're fooling yourself. So it's not a straight line. It's going to be broken. And if you want to use that information for focal therapy, you're guessing. This is really not a solution to the problem. That's why it's not done very often. Now, I've seen a good number of radiation oncologists doing this now because they're very familiar with this type of technique, but most urologists, they're not going to do it. So how do we change current technology? Well, the biopsy needles are not going to suffice. They were designed 30 years ago, and they only take a specimen 17 millimeters long. So in the old days, that was fine. You stuck in the tumor, boom, you got it. Now, tumors are mostly invisible. Even though if you can see them on MRI, there are more that you don't see on MRI. So you're not going to find them haphazardly by just poking the prostate. And that was a great study Dr. Liebman showed from Hopkins about the randomness of the biopsies. They're not where you think they are. There's no software that provides real-time tracking, representation, and recall. I'm not including MRI software there because it does that, but I'm just talking about software that is based on the biopsy. Another challenge. If you could take a longer specimen and you wanted to deliver that specimen to the pathologist, let's say you could take a 4 centimeter long specimen. So as when Dr. Raston and I was showing that movie of the needle going through the posterior capsule and working its way up to the anterior and just taking the lesion. What happens if you could just put the needle in the posterior capsule? It would go straight up to the anterior lesion, and it would take not only the lesion, but it would take the tissue on either side of the lesion. That would be great. And that information, if you could give a long cord to the pathologist, and he could tell you where the cancer was on the core, whether it's apex to base or posterior to anterior, you could use that linear information to help plan focal therapy and improve your size estimation of the cancer, even if you do an MRI. But nothing exists. If you take a 4-centimeter core and stick it in a vial of formalin and send it to the pathology lab, it's pieces before he gets it. So in order to come up with a solution, you have to solve all these problems. You can't just solve one. You can't just have a needle. You have to have all the pieces together. So I'm lucky in some ways that I retired, because then I could focus on trying to figure out how to do all this. So part of this comes from an article written by Kepner and Kepner. What they wrote in 2010 says, if I have the ability to drill holes in the prostate, and they're one hole from top to bottom or side to side, however you want to look at it, and I space those holes a certain distance apart symmetrically, and they're of a certain size, I can define what I'm missing between two parallel holes. So that's the theory behind mapping biopsies if you have the other components I just mentioned. And they modeled this out, and they showed that the tighter the holes and the bigger the drilling, you could actually get greatly increase the probability of detection. So, you know, if you're looking at the area under the curve, you see nothing like this. If you could get up to here, that would be great. So we modeled that into a real-life software situation, and one of my co-founders in the back, Dr. Craig Bear, is a software engineer, and he and I worked on this for a couple of years. And I was fortunate because of my brachytherapy experience in 1998, when Variseed, which was MMS in those days, first introduced their program. I spent 2 years working with Ted Jackson. He was a software engineer developing the real-time brachytherapy program. So leveraging that experience and knowledge, Craig and I sat down with his engineers, and we spent 2 years developing this. And what we ended up with, theoretically speaking, if you space your needles at 5 millimeters and you use a 15-gauge needle, your probability of detecting a lesion with a radius of 2.5 millimeters is 98%. That's the theory behind it. So if I can stick 15-gauge needles and take biopsies at 5 millimeter intervals, and they're all parallel, then I can find substantially all prostate cancers in the gland. So we built that program. This is the alpha test version, and it looks like a brachytherapy grid, and these are all the biopsy sites. And we don't have any needles or guns or pathology devices at this time. We just built the software to proof of principle. So that's what it looks like in transverse. And when you clicked on the needle, it tells you the length of the prostate from apex to base. So you could, if you had a device that could take one core, you could do that. We didn't have that, obviously. And this is what it looks like on sagittal, and that looks very familiar to brachytherapists, doesn't it? You've got your needle overlay. You've got the spot here that shows you where the core length is, and you got the position, and you record that. And you, just like with brachytherapy, you have the representation of the needle, because you know when you put the needles in the prostate, if you're doing brachytherapy, they don't end up exactly in the same place. They're always going to be drifted 1 or 2, 3 millimeters away, and you're not going to spend all day trying to improve it by 1 millimeter, so you have to be able to represent that in 3 dimensions exactly where it is. So that basically means clicking on the needle and dragging it over to the implanted needle, just like with brachytherapy. So there shows you that. Then here's another image. So here's the needle, the virtual needle, and here's the needle going in. And what is it doing? It's deflecting, right? Everybody sees that. So I said, wow, man, this is not going to be good. If I'm representing this and I want to use this information for focal therapy and my needle's banging up like that, that's not going to be too good. So now I have to go figure out how to fix that problem. So Michael showed these. We published this last year, needle design. So now I'm back into the lab. Fortunately, the lab is not so far from me, so we could figure out what we want to do, and we're playing with all types of trocar tip needles and lancet tip needles. Dr. Rassenhead says he likes the lancet tip needle because he can steer it. I frankly like one that goes straight, and I know it goes straight, and if I want to shoot it straight 6 centimeters, it's going to go straight 6 centimeters. So we played with the design of the tip of the needle. We finally came up with, after much testing in hydrogels that mimic the density of a prostate, this is a needle that was deflecting, and this is the final design showing there's very little deflection. And when we compared it to the bar needle, we've got 1/9 the deflection, which was an average of 0.1 millimeters from the distal part, not the entry part, but from the part that was all at the end. But innovating a needle is not just one thing, I found out, because even though I got a trocar tip, so it looks like a spear rather than a needle you draw blood, it turned out that the cannula, as the cannula comes over the bed of the needle to push the tissue into it, unless that cannula, which has got the tip to cut the tissue, actually cuts the tissue, what happens is the cannula comes over and then the needle starts to drop down. So even though you have a trocar tip needle, it's still deflecting because the cutting portion of the needle is now pushing the needle down. So we had to figure that one out. So we eventually did. So this was the first iteration of the needle. So now I want a needle, and this is 6 centimeter bed. I want a needle that could take a specimen for the entire length of the prostate if needed. So I decided 6 centimeters was the key. This is a lancet tip needle. That didn't work. So when we tested that, we saw deflection. Even though it was a 15 gauge needle, it still deflected as much as the barred needle, which was only 18 gauge. So we switched that over to a trocar tip. You can see that there. And then the other thing is, this is what the base of the core bed looks like. It's just a flat, shiny surface. So as the cannula, here's the cannula here, is cutting the tissue is cascading and according its way down to this end. So it now, if you thought you wanted 6 centimeters and you got 3 because the tissue was smushed together at the end, and you're saying, well, the length was 4 centimeters or 5 centimeters, but I only got 3. Did I not get the full length? Or did this accordion effect had? You didn't know. So then you're left in the dark. I didn't get all the tissue. So then I have hypothesized, if I put these ridges in, and the cannula is coming over the core bed, these ridges will hold the tissue in place, and that will allow me to get a consistent core. And that's important because probably you all recognize when you use the current needle technology, the mean core length is 64%. You don't get 100% of the 17 millimeters. Nobody really cares because all we cared about was getting a diagnosis of prostate cancer. But today we care about getting all the tissue and knowing where the cancer is. At least that's what I believe. So we tested this in a porcine model, and we got 96% specimen consistency, core consistency, and it was because those ridges held the tissue in place. So this is what the device, prototype of the device will look like. It's going to have a disposable needle and a reusable gun, and this is a dial where you can dial the distance between 2 and 6 centimeters. I have the prototype there if anybody wants to see it. Like I said, it's not available for clinical use. So that was software, needle, gun, 3 components. Now we got component 4. So here we are in Athens, Greece, and we're doing mapping biopsy using the old technology. Here the technician is picking up the specimen. You can see it right there, and she's dropping in the formalin. So say, it's a 15 millimeter specimen. Nobody cares. And here we are at the University of Colorado. This is their setup. They get the specimens. It comes on the needle. She takes it off the needle. She puts it on a sponge, the blue sponge. The sponge goes here in the tissue processing cassette. Then they put another sponge over it, and then it gets transported to the lab. They still have to pick it off and handle it, and it falls apart. It makes it very difficult. And you can see the boxes of all the specimens. So this is Dr. Crawford doing a mapping biopsy. This is one of 3 or 4 boxes of specimens that's going to go to the lab. So there could be 100 specimens there. They go crazy when Dr. Crawford does a mapping biopsy. And so this is the 4th innovation. This is the biopsy carrier concept. So in the operating room, we have a polyester, woven polyester device. It's labeled with 0 to 6 centimeters. The specimen goes on this tacky material here. The device gets folded over. There's a self-sealing strip. There's a patient identifier here. When it gets, this goes in formaldehyde or formalin, and when it gets to the lab, they pull it out. They look at the size so they can access it. Now, the standard tissue processing cassette is 3 centimeters long, and that's millions and millions of these. 18 million are used a year. So you're not going to change the way the histopathologists evaluate their specimens by giving them a 6 centimeter specimen, because it's not going to fit in the tissue processing cassette. So we designed it so it says cut here. So now you have 3 centimeter specimens. If this is the base of the gland and this is the apex, they're going to ink this one and they're going to ink this side, another color, and they're going to put that one piece cut in half in the tissue processing cassette. It never needs to be opened or removed from that device. It goes through all the steps of tissue processing, including paraffin embedding and sectioning on the microtome and then placing on the slide and staining. So it's never handled, so the linear integrity of the specimen stays intact. This was the hardest thing to innovate. It took over 2 years to get the chemicals right on the polyester so it could be properly embedded with paraffin and section on the microtome without fracturing. I spent a lot of time in the pathology lab, which was reminding me of my medical school days when we were in pathology. So this is what it looks like. Here it is in the tissue processing cassette, embedded in wax. One end is stained one way, one end is stained the other. You can see it coming off the edge of the microtome. And there's a tissue there unstained. You can barely see the edges of the polyester fiber. There it is on the slide and stained. And there's the green stain. This is a piece of porcine kidney. So that's the 4 components. So Dr. Crawford's been doing this in his OR for many years at the University of Colorado. And here's a typical example: a 67-year-old man with a PSA of 4.7, had a 12-core biopsy, and one of 12 cores was Gleason 3+3, less than 20% of 1 core. So now we're going to make a choice. Should you send this patient to active surveillance? Should you do an MRI? Or should you do a mapping biopsy? So we had the mapping biopsies, and this is a 3D reconstruction. The darker colors are Gleason 7s, and the lighter colors are Gleason 6, so we had 8 lesions. And these are what the lesions look like on sagittal imaging. They're all very small. They're all 2 millimeters, 3 millimeters, 4 millimeters, so it's no surprise the MRI missed them. And this is my concern about what we're doing today. Not that I believe it's wrong, I believe it's right, because we can't just rely on trust biopsy. We need to move on to something else, and MRI is the solution today. But it's not the only solution, and it's not a full solution. That's where I'm coming from. So I presented 2 papers, or the group presented 2 papers at the AUA last year. We wanted to look at how good mapping biopsy is at predicting patients who should have prostatectomy. So we had 369 men, of which 240 had prostate cancer. So 369 men came from mapping, and we had 240 with prostate cancer, and 45 of them ended up having prostatectomy, and then we could compare the mapping information to the whole mouth prostatectomy data. And there were, of the men that had prior trust biopsies, their median number of cores was 12, and of the men who had mapping biopsies, so all the trust men had mapping biopsies. When they had the mapping biopsies, the median number of cores was 50, with a range up to 120. Anyway, what it shows is that 28% of the men had Gleason 6 prostate cancer. So 3/4 of the men had Gleason 7 above, which is consistent with the other data I showed you. And what it also showed is of the 4 men that had low volume Gleason 6 disease, all of them were T2A, and one of them was T2C. So there were 5 men in there, and of all the other men, of all the other Gleason 6 that were 1 core or 2 cores on trust biopsy, the rest of them had between 4 and 20 cores positive on the mapping biopsy, and their RP stage was T2C or T3, even though they were Gleason 6, 1 or 2 cores on the trust biopsy. So these men, the ones with the 1 to 3 cores, those 5 were told they didn't need prostatectomy, but they wanted it anyway. They could have avoided the surgery. So in essence, the mapping biopsy and the 45 men that had prostatectomy correctly identified the surgical candidates 100% of the time. And then we also presented, Dr. Gutierrez presented the data on complications. We need to know what complications are when we do this procedure. So there were, one of the things I want to say about the detection rate, because Art showed some numbers, the detection rate with mapping biopsy was 75%, not 30%. And when you look at the literature, it varies between 40% on the low end and 80% on the high end. Why does it vary? And there was a nice review paper I think you showed about the variation in positive biopsies, because people don't want to stand there and take umpteen zillion biopsies. So there are papers all over the place. Many of the papers are zonal. They separate the prostate into zones, and they say, I'll take 3 biopsies from this zone and 3 biopsies from that zone. And even the group that has tremendous amount of experience, our colleagues at University of London, Hash and Emberton, they do modified because they can't stand being in the OR. So their standard now, this is a paper from the British Journal of Urology, was they skip zones. They'll go on the left zone near the apex, and then the next zone over, they'll do the base. So they're skipping sections of the prostate. Why? Because it takes too long. Now, they didn't find it really made a difference. That's why they did this. That's not what we're doing. We're putting inline cores in and doing the entire length of the prostate. But using current technology, it takes way too long. But anyway, that's what we did. We got a 75% detection rate of prostate cancer. Of the 250 men that were diagnosed with prostate cancer, 17% went on to active surveillance, 17% had a prostatectomy, 25% had radiation, 32% went for targeted focal therapy, and a handful were undecided or had HIFU. So Dr. Crawford and Dr. Gutierrez used this information to make treatment decisions. So in terms of infection rates, the infection rate with trust biopsy was 4.1%, and it was 0.8% with mapping biopsy. It was not 0. There was no association with older age or prostate volume and infections with either the trust or the mapping group. There was no association with the number of trust biopsies. That means the number of times a patient. One patient had 9 trust biopsies before he had mapping and infection, and no association with prostate size and infection. In terms of retention, there was no retention in the trust patients, but there was a 7.9% retention rate, temporary retention rate, in the mapping patients. So this is very similar to our data with brachytherapy. We have an 8% temporary retention rate with brachytherapy, so no surprise, because you're sticking the prostate so many times. But we did find, and again, very similar to brachytherapy, that patients with a larger prostate were more likely to go in retention. So it was 46 versus 64 cc's. Older patients were more likely to go into retention. And regarding retention and infection, it turns out that of the 3 patients who had mapping biopsies and had infection, 2 of those patients had retention. So retention is also a risk factor for infections in the mapping patients. I think this is really important information. I haven't published it yet. We will. But what it tells you is that if you have a man with a smaller size prostate, you probably get to send him home from the theater, from the recovery room without a catheter. But if he's got a bigger prostate or if he's older, you probably want to send him home with a catheter. And that was what I learned when I was doing them at Mount Sinai, and when I was working with Dr. Crawford at UC, he was sending everybody home with catheters. I said, you don't need to do that. The guys that are younger and smaller prostates probably do not need catheters. And we do the linear regression on retention risk. It was just age and size. It was not the number of cores. Of course, bigger prostates, you take more cores. So retention risk was, the odds ratio was 5.6 for the bigger prostates, and the odds ratio was 3.6 for the older age. So you have substantially higher risk, so manage them with catheter if you're going to be doing this for 24 hours or more. So let's skip that. So my algorithm. I don't want to change the world because I don't think we can change the world in what we do initially. And we're going to be heading to an environment where we're no longer going to be paid for fee-for-service. I think we all recognize that. We can't afford that anymore. It's close to 18% of GDP in the U.S., and no better health outcomes than Canada, where it's 12 to 13%, Lori. In Japan, it's it's 7 to 8%. England, I think it's down around 6 to 7%. And there's no better outcomes here than there is anyplace else. So why are we spending so much money? So we're going to be given a pot of money and said, okay, you got a patient with prostate cancer, you want to diagnose them, I don't care what you do. Go order 25 MRIs, go order 15 genomic tests. You'll be out of money before you take your first biopsy. So we got to start thinking of what should we be doing. So my idea is, okay, we still got to do a trust biopsy. You still got to do a trust biopsy. Now, I think we can get MRI down to an inexpensive test. So if we can get the test down to a reasonable cost, then everybody should have an MRI. Because if you have a big lesion and the patients can have PIRADS 4 or 5, that's easy to hit. 1 stick, 2 sticks, you don't need to do random systematic biopsies. That would be cost effective. Then the patient goes on to treatment because those patients mostly have Gleason 4 and 5 disease. Easy, inexpensive prostatectomy, that's going to be a money saver. It's this, let's take the Gleason 6s, which is 75% of the patients, and let's start doing genomics, let's start doing serial MRIs, let's start doing biopsies every year, and then 50% of those men within 7 years end up having treatment. That's not cost effective. So a strategy after they've had their ultrasound and maybe MRI, ultrasound biopsy and MRI, is my vision is these men will go to mapping. And with mapping, if you find out with this fine system that we're developing that there's just 1 or 3 or 4 cores of Gleason 6, that patient can go on active surveillance. It's like a colonoscopy. Come back in 5 years. You don't need another PSA. You don't need another MRI. You don't need another biopsy. Let's just look at you again in 5 years. That's a third of the patients, at least. That's an extremely cost-effective way to manage it. And to take a patient to the OR to do a mapping biopsy as an outpatient procedure is not expensive. The ASC reimbursement for that in average Medicare in the U.S. is $2,000. So for $2,000, you've got 5 years at least, I think, of safety in watching that patient, and maybe never have to do anything else in that patient other than check his PSA in 5 years. For the group that have the type of disease that can have focal therapy, this system may give us the ability to find all the discrete lesions up down to 2.5 millimeters in size and ablate them with a co-registration format. Not co-registering the index lesion, but co-registering all of the lesions that you believe to be ablated, need to be ablated. Now, there may be mixed 6s and 7s, and you don't want to do the 6s, you just want to do the 7s. But my feeling is, if you're in the OR anyway, you've got 2 7s and 2 6s, do all 4 of them, especially if they're only 0.2 or 0.3 cubic centimeters in size. What energy you use, that's going to be up to your decision. And you're going to find, because this is what the data shows, when you do the mapping biopsies, a subset that really have surgical disease. They'll have the Gleason 8 to 10s, and maybe there'll be about 10 or 15% of these patients who go through mapping. And you'll find these Gleason 8 to 10s when they are 0.2 or 0.3 cubic centimeters. I feel, I don't have any proof of this, but I feel we can further drive down the death from prostate cancer by finding these bad actors much earlier. And with a system such as this, if we can actually achieve that, that would be a big benefit to our patients. So that's my vision. Now, I left my fellowship at Memorial in 1986. I was 1 year after Laurie. He was my mentor. And we were at the end of the open seed implant period with which Dr. Whitmore had developed. A great program, but we could see the disaster that was heading with that program. And I went over to Sinai in 1986, and in 1990 I started a brachytherapy program. And my co-fellows were Peter Carroll, Michael Liebman's former boss at San Francisco, and Paul Russo and Bob Stevenson. Everybody was then enthralled with the anatomical prostatectomy. And here I'm at Sinai in 1990 starting a brachytherapy program, and everybody says, "What are you, nuts? Why are you doing that?" It took a lot of heat, but no, everybody knows what the real-time brachytherapy program is today. Everybody uses that program in the entire world with real-time imaging and real-time software adjustments of dose. And I think the people who know and are comfortable recognize that it is as good as prostatectomy in low-risk patients. It's better in terms of quality of life, and Dr. Crook's going to talk about tomorrow. And in high-risk patients, we heard yesterday, the only way to treat these bad players is with combination therapy. So do I have a lot of confidence that this is going to be successful? The answer is yes, but it needs a lot of work, and it needs a heck of a lot of testing, which we need to do to prove what I'm saying is actually true. So in conclusion, the 3D transperineal approach utilizing software, newly designed needle and gun, and a pathology carrier system that has the capability of detecting lesions as small as 2.5 millimeters. Targeted focal therapy requires precise localization of all significant lesions and then a roadmap for treatment planning. This is interesting. The jury is out as to whether some or all lesions need to be treated. So remember, we had 2 talks, basically the same data, looking at the genes of Gleason 6s. There were 4 patients in that study from Roswell Park, and they were all bad actors. So you might think, if I'm doing a mapping biopsy and I found 6 discrete Gleason 6s and 1 or 2 of them is large, I don't want to send 6 specimens for genomic analysis because that's going to be very expensive. I could just put them all together and say, do the gene map on this, or do a Oncotype DX, whatever you want to choose, or a Decipher. And if all of them together come out good, then that patient's great for surveillance. So I think we can get, by having our hands on all the tumors by this, what I would call virtual prostatectomy, and doing genomics on the Gleason 6s or maybe some of the Gleason 7s, and they look good by batching them all, that patient probably would never need to be treated at least for 10 years, maybe longer for prostate cancer, and that would also be very cost effective. The proof of success, lesion eradication, they still need to be determined. One of the things that we will eventually get to, I hope, is if the system works out and serves as a virtual prostatectomy, and then you can go ablate the individual lesions, you can use the same map to go back and then biopsy them 6 months to a year later to prove you have ablated the areas where the cancer was detected, and then be able to actually have a focal therapy platform. And again, I must say the devices I showed you are not approved for clinical use as of yet. Thank you.